to go.
Great. Thank you, Isaac. And you all are not seeing double. It is my distinct pleasure to welcome our speaker today for our monthly COVID-related nursing home quality improvement webinar series. We're really fortunate to be joined today by Dr. Sapna Kripalani, who is an expert in long COVID, a very challenging condition to treat. She is an experienced primary care physician who works at Vanderbilt and really played a key role in establishing the long COVID clinic at Vanderbilt, which serves patients not only in Nashville, but around Tennessee and the surrounding region. Dr. Kripalani has kept up with the literature in this area and treated patients personally who are struggling with this condition that we just don't have a good understanding of in medical care. And we're really fortunate that she's joining us today to share some of her latest insights on what long COVID looks like, how to differentiate it from other conditions that patients may have, and what we can do to help patients who are experiencing long COVID symptoms. So, Dr. Kripalani, thanks so much for joining us today. We'll turn it over to you.
Well, thank you so much, Sunil, and I appreciate that introduction and really delighted to be here. I'm going to see if I can share my screen and my slides with you all. Are you all able to see that okay?
Looks perfect.
Okay. All right, great. Well, once again, thank you for the invitation to be here. I appreciate the opportunity to talk to all the attendees today, and thank you for the invitation from this organization to speak about long COVID. It's something that is very important to me. It's something I've been working with for nearly 2 years now, and really is an important thing that we're just really starting to get to understand more about. So my goal today is really to talk a little bit about the background of long COVID and how it emerged, and then really to try and focus in on this particular population, those that we see in nursing homes, as well as the geriatric population that many of whom reside there, to see how we can particularly target some of our therapies towards this population. I have no disclosures to report, and I would like to add that some of the data that I'm going to be presenting is from a variety of different researchers and clinicians across the country and even globally. As more and more data is emerging, we're really pooling our resources from various other places, and it's been really helpful to use data from other countries as well, where they've been just a few months ahead of us in the pandemic, both from initiation as well as from the several waves that have come across over the last couple of years. So I wanted to take a step back and really just talk about the emergence of COVID-19 and the acute infection, and then how that progressed into our understanding of what we now call long COVID. And some of you may have seen graphs that look a little bit like this that show us the onset of COVID infections as we first understood it way back early in 2020 or in late 2019. And this dotted line on this graph represents the onset of symptoms of COVID-19, the typical symptoms we've heard of with cough and fever, shortness of breath, chest pain, sinus symptoms, all are represented at the time of this dotted line, which is kind of 0 on the graph here. And we've understood that, you know, for most people, and especially early on, we recognize that the exposure to this virus seemed to occur about a week or two before emergence of symptoms. And as we started to understand more about testing people, we recognized that the majority of patients were testing positive in that first week or up to 2 weeks after development of symptoms, and that the ability to test positive or to isolate that virus from both the nasopharyngeal as well as the respiratory tract seemed to peak at about week 1 and then promptly declined. And that really followed the course of symptoms as well, in that we seem to see people be most symptomatic for the first 1 to 2 weeks, with some declining symptoms over the next 2 to 3 weeks. And that in most people, by week 4, there seemed to be primarily a resolution of their symptoms. Early on in the pandemic, we thought, after about week 4, this was a pretty self-limited infection. Sometimes it was severe in some people, but in most people it was mild to moderate. And that by week 4 or a little bit later, most people had returned to their baseline, and there were no further symptoms. But within about 3 to 4 months after COVID first became, such a big pandemic across the world, we started to recognize there was a large population of people who were not making that full recovery. And we started to see people emerging even, 6, 8, 12 weeks after their initial infection, who were reporting that they continued to have profound fatigue, significant shortness of breath, some of whom were even requiring oxygen supplementation. They were having chest pain, some of whom were even having more severe complications such as blood clots and kidney issues, hair loss, a variety of things. And so, we started to realize that there was more to it than just this acute infection that resolved like a cold and you go back to normal. And as months went on, there were people who were continuing to suffer. We realized that it was not a disease that was affecting just the respiratory tract, but was affecting multiple organs. So we saw neurologic complications. There were kidney complications. It even seemed to be affecting the endocrine and cardiac systems as well. And some of those symptoms were pretty severe, anything from arrhythmias to blood clots. People were experiencing all kinds of rashes and vascular problems. You may have heard of things like COVID toes. People were having nausea, vomiting, and other gastrointestinal symptoms. So it was really a very broad virus that was affecting a lot of organ systems. And that was relatively unique to COVID compared to a lot of other viruses we had typically seen. And as time went on, we really saw that there were over 200 symptoms that people were reporting, both with COVID as well as that lasted longer, and we were starting to call long COVID. We started to see that these symptoms were prevalent in a pretty large percentage of patients who had had acute COVID symptoms. So this study here, this is a graph from a study that was published in 2021 that showed even this was done at 7 months after acute infection, that up to 70% of patients in this study were still reporting persistence of fatigue. They were saying they had post-exertional malaise, which is a specific worsening of fatigue after any sort of exertion. And that could be physical exertion. It could even be emotional or stressful exertion. But they were having worsening fatigue. More than 60 to 70% of patients were reporting this. There was also a lot of complaints about brain fog and headaches and memory and cognitive issues that were associated many months later. So, this really started to draw more attention to this condition, and we started to realize that, if a majority of patients were experiencing these prolonged symptoms, it was really something we needed to pay attention to. Interestingly, as people were recovering from COVID, and especially those who were starting to experience these prolonged symptoms, they weren't just getting better every single day, as we would normally expect with other illnesses. So they would find that they would have several days that were better, and then that would be followed by a crash. And so we started to realize it was this waxing and waning, up and down recovery process that was a little bit different from other viruses. When they surveyed patients, and again, this was the same study that looked at patients 7 months later, they found that there were certain things that seemed to trigger those flare-ups. So stress, again, even emotional stress seemed to be a trigger for people to have a setback in their recovery process. Other things like alcohol or physical exercise, mental activity, and even hormonal changes, such as with menstruation, seem to trigger a little bit of a worsening of symptoms. And this seemed to be replicated in multiple studies subsequently. There was also a bit of a challenge in terminology. So, long COVID, as I'm calling it here, has gone by a lot of different names, and clinicians and patients were struggling to find a term that everybody could settle on so that we could all use the same verbiage. The NIH came out and officially called it PASC, or post-acute sequela of COVID, and that was early in 2021. The CDC and World Health Organization chose to use post-COVID conditions, or PCC. In the general population, people were calling it long COVID, and that's a name that's kind of stuck because it is that. It's COVID that seems to continue on for a long period of time. and that seemed to make sense. And then other patients were calling themselves long haulers. So there's been a lot of different terminology. And there's been a lot of definitions as well in terms of how do we define when someone is done with their acute recovery and when do we start calling it long COVID. And there's been a variety of definitions. Some people have used 4 weeks, others 6 weeks, in terms of what the exact time frame is. But probably the best definition that I've seen has come out from the World Health Organization. And they defined 4 primary criteria for calling something long COVID. So first, they have to have a history of probable or preferably confirmed SARS-CoV-2 infection. They need to have had symptoms that occur at least 3 months from their initial infection. So they're saying that, really anything within the first 12 weeks can still be part of that acute recovery period. And we really shouldn't call it long COVID until after that. The symptoms need to last at least 2 months. So sometimes people can have something else that comes up in addition to their COVID symptoms or long COVID symptoms, and it's hard to know if it's related to that or not. So they want there to be some consistency in the duration of symptoms. And we need to not have an alternative diagnosis to explain their symptoms as well. And that's important because it's always possible that there's another disease process that's flared, and we can't put all of that into the bucket of long COVID. But that's probably the best definition and most concrete that I've seen out there. And in the last year, we also have ICD-9 codes so that doctors can better code for these illnesses and that we can better track these patients as time goes on. There's also been a lot of interest, of course, in trying to predict who's going to get long COVID and who's not. And several studies have looked at finding features in patients that are going to help us determine whether this is someone who's likely to go on to develop severe symptoms down the road, or are they someone who's likely to fully recover. And it's been more challenging than we expected. Initially, there was some thought that depending on how severe your initial symptoms were, that would determine whether or not you were likely to develop long COVID. And we found that that really wasn't consistently reliable. As this graph shows you here, it looked at patients who in these blue bars had either mild or severe acute COVID. So that's the acute period. And try to look at them several months later to see what was the likelihood that they went on to develop ongoing symptoms of fatigue or smell changes, headaches. And you can see that in each of these graphs, the acute symptoms didn't necessarily predict whether or not the person would go on to develop long COVID symptoms. In the setting of fatigue, there seems to be a little bit of a correlation, but you can see here that for symptoms such as trouble breathing, those with mild symptoms were just as likely to develop long COVID symptoms or long COVID shortness of breath as those who had had severe illness. So it's really not a reliable metric to determine who's going to go on to develop long symptoms. Of course, we've all tried to understand better as time has gone on what really causes long COVID. What features cause it? How is this process happening? What is this virus doing to our bodies that are making some people continue to have symptoms months or even years later? And at this point, really, we've seen some good articles and some good studies coming out, really trying to test these hypotheses and come up with some suggestions of what's the biomedical pathway by which this is happening. And there's really 6 main mechanisms that have emerged as possibly contributing to long COVID. And those are inflammation, autoimmune system dysregulation. There's also been some thoughts that there's persistent virus. So this COVID-19, SARS-CoV-2 continues to replicate in the system, and that it's actually, there's a reservoir of it somewhere in the body and it's continuing to replicate, and that's why it's continuing to cause symptoms. We've also seen some suggestion that there might be reactivation of other viruses. And then there's some direct tissue injury. So I'm going to go into that just a little bit and spend a few minutes on each of those topics. So I mentioned inflammation, and we know that the initial infection with SARS-CoV-2 can often trigger a very profound inflammatory response in people. And early on, we realized that people who had the most profound inflammatory responses were often those who ended up with severe lung inflammation, and many of those ended up in the ICU and intubated. And much of that was not so much because of the virus, it really was the body's own autoimmune response to that virus. And the thought is that somehow this virus is causing severe T and B cell stimulation, and that's causing that inflammation, which is then causing direct attack on the organs. And we've seen this kind of thing before. In the setting of reservoir, there has also been thought that there's virus somewhere laying dormant and replicating at a slower rate within the body, and that perhaps that is why there's this inflammatory response. Some studies that have looked at that a little bit in more detail in recent months have been published, and there's been a lot of thought that maybe the gut is a source where there's persistent virus. And when they did some studies looking at gut biopsies, they were actually able to show that there was persistence of SARS-CoV-2 RNA in the gut mucosa for as long as 7 months after the initial infection. And we've seen this type of thing before, even with viruses and infections such as Ebola in the past. We've seen that they could isolate the pathogen in saliva and semen and other body fluids many, many months after the initial infection. And so we're starting to see something similar emerge in SARS-CoV-2 as well. Another study actually looked at fecal presence of the viral RNA, and they were able to isolate the SARS-CoV-2 from fecal material in patients who had been infected even 7 months after the initial infection. And in some studies, and this most recent one showed that even as, although in the respiratory tract, they could only isolate it in SARS-CoV-2 for about 14 days afterwards, in the stool, they were able to isolate it as much as 300 days. So almost a year later, they were still able to find presence of virus. So that again supports the idea that the gut may serve as a reservoir for this virus. The autoimmunity, as I mentioned earlier, might be one of the mechanisms for persistence of symptoms and long COVID. And again, this can be because of the virus triggering a bit of molecular mimicry. So it actually triggers development of self-antigens and reaction to that. And so the thought is that this may cause there to be autoimmunity against portions of the brain, certain organs, and that may be a way in which we're seeing long COVID symptoms persisting. And then reactivation is another hypothesis. So this is reactivation of other viruses. So not so much the SARS-CoV-2 reactivating, but that perhaps other viral infections that have been dormant are now reactivating as the immune system is busy fighting off COVID. It's allowing those viruses to reemerge, and perhaps that is a basis for people having prolonged symptoms. And interestingly, they've been able to isolate viruses such as Epstein-Barr virus in high quantities from certain body fluids in patients who are suffering from long COVID. So there may be other viruses that are in play here as well. And then lastly, the tissue damage hypothesis. So the thought is that there's many aspects of SARS-CoV-2 that are triggering clotting, and that this clotting cascade is then triggering direct tissue injury. And as we know, this virus has a very unique ability to go into organs, to cross the blood-brain barrier, and that it may be in that way triggering direct organ injury. And by triggering this clotting cascade, the thought is that there may be slight, very, very small microclots, which are really hard to detect even on traditional imaging and ultrasounds and things that we normally do to look for clots. We're not able to find them because they're so small, but they may be causing very microscopic levels of injury to the lung, to various organs, to the brain, that are then causing change in the tissue structure there and leading to some of these prolonged symptoms. So overall, the long story is that we don't fully understand this disease process. And right now there's a flurry of activity as researchers are trying to perform studies to look at various biomarkers and hormone levels and various things to help us better understand who's going to be at risk, How can we predict it? And then how can we diagnose it? Because at this point, long COVID is really a clinical diagnosis. We use a constellation of all of these symptoms, and we say, as the World Health Organization pointed out, that we need to have, evidence of an infection, evidence that they're having ongoing symptoms, and not have another explanation. But that's all fairly subjective, and it would be really nice if we had some blood tests or biomarkers that would help us better identify patients who are suffering from this condition. So there are a lot of hypotheses out there, and a lot of early studies going on, people looking at things like cortisol levels and biomarkers, looking at angiogenesis and clotting that might help us better be able to identify and diagnose these patients. So in the meantime, what can we be doing to prevent long COVID? And I think one of the number one things that we've seen as a tool that we can use is vaccination. Some early data looked at vaccination and tried to see not only, how effective is it at preventing COVID infections, but really how effective is it in preventing people from going on to develop long COVID if they have breakthrough infections. And there was some really very exciting, promising early data that said there was up to a 50% reduction in long COVID in patients who had been vaccinated. Unfortunately, as time went on, that data may have been a little overestimated, and some more recent data, including this one that was published just a few months ago, said that it may not be that robust of a improvement, but that there still seemed to be somewhere between a 15 to 20% reduction in the likelihood of developing long COVID symptoms in people who had been vaccinated. I can tell you just from my own clinical experience and in patients that I'm seeing, the majority of the patients that I see in my clinic who have the most severe long COVID symptoms are those who have not been vaccinated, or at least were not vaccinated prior to their initial infection. And so I really do think there's probably more to be learned about vaccination, the role it plays in lowering this risk. So moving on to talk a little bit about past or long COVID, particularly in the geriatric population. And I think it's important to note that 10% of our current global population is currently 65 and older and would fall in this category. And globally, we know that rates are as 80% or above of the deaths that we've had related to COVID-19 are in this age group. So this is a particularly highly vulnerable and high risk population, both from complications of acute COVID as well as from the long COVID symptoms. Data, that came out from looking at residential facilities showed that 70% of individuals in facilities currently have some sort of cognitive decline from their baseline. And we know that a decrease in cognitive function is a risk factor for developing long COVID and to have more significant complications of long COVID. Along with that, mood changes, anxiety, sleep changes have also been associated with long COVID, but are also more pronounced in this population. So, we know that these patients are at a higher risk of having not only having these symptoms at baseline, but also being more at risk from developing worsening of these symptoms after developing COVID. So all the more important to really try and protect them from getting infected if we can, but also to be aware of long COVID symptoms in this population if they do develop the illness. A study that was published just recently really highlighted this and looked at this age group in particular, and looked at patients. It looked at 87,000 patients who were age 65 and above. And interestingly, it found that over 32% of these patients who had had long COVID reported at least one new or worsening symptom that required medical attention after developing acute COVID infection. And when they compared this group to a cohort that had not been infected with COVID, they found that it was about 11% higher risk. So it was significant. Also, interestingly, this graph shows a breakdown between patients who are in the 65 to 74-year-old age group. And those that were 75 and above. And you can see that based on these bar graphs, that those that were above 75 were at even a higher risk of developing various symptoms related to COVID compared to the slightly younger age group. So age is definitely a risk factor, and increasing age increases that risk. Of course, there was also a higher risk for those who ended up needing hospitalization because of COVID infection. But in this study in particular, they found that being male was a higher risk, and that certain races, such as African American race, also seem to have a slightly higher risk of having long-term symptoms. And then coming back to our geriatric and nursing home population, I think one thing that is starting to emerge and supports what we've always known is the risk of falls. And we're starting to understand how long COVID in so many ways can really exacerbate the risk of falls, which is already such a big problem in nursing homes. As many of you know, 320,000 hip fractures a year occur in across the United States, and many of those go on to develop to require hip surgery. But of those patients who require surgery, up to 32% of those patients die within a year. So this is a significant risk and increased marker for mortality in this patient population. Falls also are responsible for 3 million ER trips a year. And there's a significant cost associated with that as well. So, falls are something that is, are very, concerning in the nursing home population, but that we pay attention to. And I think as we're seeing long COVID emerge in these populations, we're realizing that that can further exacerbate that problem. Not only can long COVID, because of all of the cognitive effects and changes that occur, cause falls, we know that long COVID can also exacerbate pain. And, as we know, having more pain affects quality of life, it affects mood, it affects your overall well-being. So it can significantly impact this patient population. We know that COVID can actually increase pain levels. And part of this is thought to be due to the mechanism of it affecting nerve endings and triggering hypersensitivity of nerves, that it can actually create new muscle or even joint pains. But we know that for folks who have underlying pain, it can exacerbate pain that was already there. Pain itself can lead to fall. So kind of coming back to that problem again, it can be an exacerbating factor. But not only that, treatment for pain can also put people at higher risk. So pain medications can affect cognition, it can cause confusion, again, it can cause falls, but pain can also affect people's ability to, eat and have an adequate appetite, can lead to malnourishment if they're in chronic pain. And then just the reduced interest in mobility when you're in pain can cause people to become deconditioned and become weak. And we know that that can happen very quickly in an older population. So again, that's another mechanism by which long COVID is something to really be aware of for people in nursing homes. I think one thing that's also important to think about is staff. And just like in all medical settings, I think it's important to acknowledge that nursing home staff can also be susceptible to long COVID. And although, we think that vaccination in these groups can help reduce your risk of developing an infection and reduce your risk of having long COVID, it doesn't guarantee that you won't get it. And so I think it's important for staff members to recognize that their own symptoms can affect their ability to deliver adequate care to their patients. They should be aware of any cognitive changes that they're experiencing. They should report any issues with confusion or brain fog or things that might affect their performance. And that it's important for the workplace to be supportive of their staff members who may also be trying to care for themselves and recover. There has been lots of new data that's come out that might affect this population as well as others as far as long COVID and what other potential side effects may be we may be shedding more light on as time goes on. So I know I mentioned things like fatigue and shortness of breath and other symptoms that we think are more in the the earlier phases of long COVID. But as time has gone on, we're starting to see that there may be an association between COVID infections and other disease processes that are going to emerge more as we go forward. There have been some researchers looking at long COVID and COVID as triggers for developing Alzheimer's dementia. And compared to controlled groups, there seems to be a higher incidence of patients being diagnosed with Alzheimer's among those who have had COVID infections. We're also seeing increased risk of other diseases such as diabetes and trying to understand how there may be some metabolic effects there. We're seeing other neurologic outcomes, even psychosocial and psychological effects such as depression and anxiety at a much higher rate in patients who've previously been infected. So I think there's going to be more and more coming out about how not only are there some earlier symptoms, but there may be some more chronic diseases that are associated and exacerbated by COVID infections. So there's still a lot of challenges to finding a therapy. There's a lot of patients who are out there desperately waiting to find some solutions. I think we're still in the process of understanding the disease, finding ways to diagnose the disease, and really just in the early stages of actually trying to find therapies that are going to be able to help these patients. As I mentioned earlier, there's over 200 different symptoms. So there's a lot of different presentations for long COVID. And as some people have said, everyone's long COVID is a little bit different. That presents a challenge to people who are trying to study it. And then, as I mentioned, we're still not sure about the actual background. The biochemical causes of this are still remain unknown. So we're getting there. There's been a lot of financial investment, and I think that over the next year, we're really going to be seeing some changes on that front. So in summary, long COVID, we're starting to see some newer studies showing that although initially we thought there might have been maybe up to 30% incidence, newer studies are saying maybe more like 12% in the general population, but we think that in the population over the age of 65, it's still over 30% of patients reporting at least one symptom related to long COVID. So it's still quite prevalent. There's still ongoing research to understand the cause, as well as finding biomarkers to better diagnose and identify these patients. And then trials are ongoing to try and find immunomodulating medications or anti-inflammatory medicines or things that are going to be able to help break up some of these pathways that are triggering long COVID. I think an important part of it is really for us all to be aware and to eliminate skepticism, both in our medical community as well as in the community at large. Because the people who are suffering from this often look normal, sound normal, and in many cases sometimes are normal. And then the next day or the next week, they may have significant symptoms because of the up and down nature of this recovery process. So in the geriatric population, I think it's important to make sure we have a comprehensive approach and that we're thinking about all of the factors that go into how these people present and how these people are living their lives. So, thinking about falls and thinking about how their illness might be affecting their physical functioning, their emotional function, their appetite. I think it's also important to recognize that this disease may exacerbate other underlying medical conditions that they may have, such as diabetes and heart disease. I think keeping in mind some of the other social determinants that are going to affect how these patients present and what their background is, that there still are a lot of disparities in the patients who are coming in with these diseases. We need to be cognizant of that and be willing to help find solutions to those things as well. And then I always like to mention that caregivers, including those within healthcare settings as well as those at home, need to be aware of what's going on and be supported as well. So that's an important part of long COVID care, is supporting the caregivers. I like to mention that long COVID has been listed as a disability. And so for folks who have been in the workforce who are not able to now, they are able to claim disability benefits if it applies. And I thank you for your attention, and I welcome any questions you may have about this topic.
I can ask a question just to get it ticked off while the folks might think about them. But is there any sort of research that indicates that, or doesn't indicate that people who have long COVID are less likely to test positive for COVID again? Or like, is there any sort of research into that space?
I haven't seen any research saying that they are less likely to test positive again. In fact, I have seen some patients, I've seen many patients actually who've had long COVID and have gone on to make some recovery, but then get COVID again. And so although you would think that they might have an increased resistance to getting reinfected if they have ongoing antibodies and things like that, I'm not seeing that clinically. I'm seeing many of them get COVID another time. And unfortunately, it can many times lead to a significant setback in their recovery. So I think that I'm encouraging my patients, even those who have had long COVID, to still plan to get vaccinated if they're open to that, because I think a second infection or even a third infection can be even more detrimental.
Interesting. Thank you.
Are there any other questions I can answer?
I'll ask one. Thanks for that great presentation. Until we have more research to customize treatment for long COVID patients, if patients do present with something new like diabetes or falls, would you recommend treating them in any different way? Because it might be part of a long COVID symptom complex, or should they be treated and evaluated in the similar way that we would normally do that?
Right. No, that's actually a really great question, because, at this point, we don't have any directed therapies towards long COVID itself. So all of the treatments that we're implementing for patients with these conditions, even if they're related to COVID, follow what we have always done for them. So if they develop diabetes or they develop other medical complications, we would treat it in the exact same way, with the idea that sometimes there's some recovery. So I have seen some patients who developed a worsening in their diabetes, for example, and we had to escalate their medical treatment. We had to increase medications or increase their insulin dose. And then as time went on, and as they started to recover, we were able to bring their doses back down. And so it's very similar to what we would do for anyone who was in a similar acute illness or chronic illness process. The treatment is very much the same. And the same goes for other complications, whether it's fatigue or weakness. Oftentimes we'll put them in physical therapy and try and help with balance therapy and things like that. And so a lot of them are more supportive ways of care, since we don't have a targeted long COVID treatment.
Great, thanks for that.
Sure.
All right. Well, if there's no more questions, I think we can just end a few minutes early here. I went ahead and sent a link in the chat for our session evaluation. If you all could complete that if you have the time, it'd be greatly appreciated. And I really want to thank Dr. Kripalani for sharing her expertise with us here today. Really enjoyable. I learned a lot about long COVID. Something I hadn't really thought about all that much, but it was really interesting to hear all the kind of different research into it and kind of how we can treat it going forward. So thank you so much, Dr. Kripalani. And yeah. I'll disseminate the chat afterward, or excuse me, I'll disseminate the recording afterwards to kind of our project listserv. So you guys can all kind of send it to colleagues, or if there's anything in particular you'd like to watch again, you're able to do so.
Thank you again for giving me the opportunity to be here. I appreciate it.
Of course. All right. Thanks, everyone. Take care.
Thanks.